Hi, good morning. Thank you so much for everyone coming here today. Welcome to MassHealth. My name is Rachel Madden. I'm the Chief Operating Officer. I'm sorry that you're getting the understudy. Crystal Floyd, our Executive Director, can't be here. However, even if she could have been, I probably would have checked her out of the way because this is something that is very near and dear to my heart. In past life, I worked for the Executive Office for Administration and Finance. I worked very closely with this core team with Emily, Lynn, both on this particular initiative at its conceptual phases, but also on many other issues to address homelessness and housing stability. So it is my great honor to be here today to welcome you all. I can't tell you how excited I am to see this actually moving to implementations. I know it's more in the pilot phase, but definitely will be on the conceptual phases so many years ago. Excuse me, I went to the Bruins game last night, so I'm a little hoarse. I also went to game 7 on Tuesday, so I'm very hoarse. But that's a whole other story. So I will turn it over to Lynn Tordo, but I will add one thing before I do. That part of my excitement is the fact that I did turn it over to Lynn Tordo because I have a small case of hero worship and always have. I can't think of anyone in the Commonwealth who's done more to address homelessness and housing stability than Lynn Tordo. So it is my great honor to turn it over to Lynn and to also say that I'm so happy that I got 3.5 years to work with you because now I can call you my good friend.
Sorry, we're gonna have to take a pause for a second, actually, because
that was such a great entrance.
the folks on the webinar can't hear very well, so I think we have to call into the system.
The number is, shoot.
The most important stuff is coming up later.
Actually, can you?
How did that work?
Let's see. Do you want me to say something?
Yeah, if folks on the webinar, can you hear us? Can you type into the box? Say,
Sound is
hear
better, we're good.
Okay. Sound is better, great.
You can hear me?
Mic is on, I think. Green.
Shall I go? Okay. All right, quickly, because we have a lot of important work to do. Thank you so much. For those of you who just came into the room, my name is Lynn Tordo. I'm the Executive Director of the Interagency Council on Housing and Homelessness. And I am very excited to see all of you here today and know that there are many more of you on the phone that are dialing in to hear about this really important initiative related to MassHealth support for tenancy-related services for people who are members of their the MassHealth ACOs, but many of those folks are folks that we all work with, those of us that are working in the housing and in the sheltering and business. This has been a long time coming, as Rachel had mentioned, and thank you, Rachel, for that very kind introduction. It's very sweet. It was always my pleasure to work with her. We are of the same mind. Let's just get it done. It doesn't matter who gets credit for it. Let's just get it done. Anyway, so I do want to just underscore that this is a great opportunity for you to hear about just what those flexible services mean, who is eligible for them, and the kinds of partnerships that we are hoping to create between the accountable care organizations and the service organizations, such as you out in the community. This has to be a partnership. ACOs are not in the business of providing this kind of service, and very much need your support, your partnership, and your expertise in order to implement this very important initiative. I do want to underscore that I'm really proud to be part of an administration that has taken on the issue of the correlation and the need to facilitate the partnerships between housing and service organizations. Our relationship through the ICHH with support from Secretary Sutters, Secretary Keneally, and Undersecretary Chan, and formerly Undersecretary Cornegay, to make these, to force these partnerships, I think has resulted in much better outcomes for the families and the individuals that we serve. So thank you very much again for coming, and I'm going to turn it over to Jane Banks, the Assistant Undersecretary at DHCD, for her welcome, and want to say that how much that EOHHS agencies value the partnerships that we have with DHCD, and most specifically with Jane and Ika Malarkey, who is the Associate Director for Housing Stabilization. So thank you very much for your support. Thank you. So I'm just going to make it super quick. I think that everyone here knows that we are getting ready to procure the family system, and we're looking at this as a really great opportunity for EA providers to be working with the ACOs and flexible services around stabilization in particular, and how they can partner together to provide really strong services for families as we place them into permanent housing in order to keep them housed and sustaining their housing moving forward. So this is really a great opportunity. It's a great initiative, and it's a great collaboration between all of us. So we're looking forward to this. Thank you all for coming. I'm hoping that there's a lot of EA providers on the phone and on the webinar. So thank you very much.
Morning, everybody. Morning. All right. You guys are awake now. Okay. I'm Emily Cooper. I am the Chief Housing Officer at the Executive Office of Elder Affairs. Some of you know me from that job, and some of you know me from years and years. And as I said, this is sort of like a little high school reunion or college reunion or whatever. In fact, elementary school, my colleagues from elementary school reunion, who I don't think came to our high school. That was a big one. So although I work at Elder Affairs, I have been discovered. I was hiding out in Elder Affairs working on housing issues, and all of a sudden people started saying, wait a second, you know about housing. And so now I'm not just working on housing for older adults. I'm really kind of advising when asked around other issues, in particular this new program at MassHealth. Ironically, which is not for people over 65. So even though it says Executive Office of Elder Affairs, it's just to say that I'm talking. So I want to welcome you all here. I appreciate you coming out. Thank both DHCD, ICHH, and Mass Housing really stepped up as to pull this off. We felt that it was important, and you're going to hear all about this today, but we felt that it was important that housers, whether you're working in homelessness prevention, whatever you want to call yourself, really hear about this new resource and be thinking about how best to take advantage of it and to leverage it into the work that you do. To let you know, we had a companion workshop earlier this week with the healthcare agencies where we did really high-level housing 101. What is a housing authority? I mean, that kind of very basic, you know, how does the EA family shelter system work? Because this is all new to them, as I'm sure a lot of this is going to be new to you. I want to make sure if you're in the room or on the webinar that we have your information, meaning that if you signed in the room or you signed in on the webinar, especially with your email address, because we will be sending you information as it comes available that's available to the public. So if you'd like to know those sorts of things, make sure that you sign in. And I want to just level set. You're going to hear a lot of new terms, new acronyms. I may jump up a few times. I'm trying to be the translator and kind of say when she says this or when he says that, it means X. So just bear with me. I hope I've already warned them so they won't think I'm totally rude. But I also encourage you to ask questions. We're going to have time in the room. If you are on a webinar, you can type into the box that says questions. We will be kind of reading through those as we go along, and we may say, you know, when we get to the question and answer time, we'll pull some from the webinar as well. The webinar is being recorded. Having said that, we're not quite sure how big it is and how we're going to be able to send it out or post it. So stay tuned. That's why we asked for your email address. And the folks on the webinar, there are 3 handouts. And in the room, if you didn't get them, they're in the back of the room. It says 3 of 5 on the webinar, but there's only 3. That's just a manifestation of the webinar logistics. So that's kind of the technology. That's as much as I know about technology, frankly. What is the purpose of today? It's to tell you about a new MassHealth program that is being, as Rachel said, you know, pulled together now. It was conceptualized and now it's being framed in order to launch it in January. So we're still building it. And I think part of the goal of today is to tell you this information for 2 purposes. One is to think about how your people that you work with, your residents, your consumers, your participants, can get access to these resources or might be eligible for these resources or on an individual basis. The second is whether your agency from a strategic basis wants to think about partnering with one of these healthcare organizations in the delivery of these services. And whether you almost want to contract with them. So I know that we have a variety of people in the room, range in a variety of roles. There's probably case managers and their executive directors. And you will hear the information from a different viewpoint. But we're trying to give you the information for multiple purposes today. So just your questions, I think, will probably reflect that, and our answers may reflect that as well, just depending on kind of, I may say, oh, you're thinking about this from an individual level or an agency level. I will also say that MassHealth serves, I don't know the number, a gajillion people in the state. And there's a whole lot of acronyms that go with it. Some of these you may know, and some of these you maybe, I have no idea, right? All of us are housers. I am not, this is as much healthcare speak as I say. But what I wanted to mention this is because you're working with people that may be on a variety of MassHealth type of products. This is just a smattering. There's even more. There's waivers, there's fee for service, there's all sorts of other things. We're just talking about that red circle of ACO. We're talking about one specific MassHealth product. It has a lot of members. How many members? A lot.
Yeah, like 900,000.
Like 900,000. It has a lot of members, but it is possible that you are working with people who, you know, you're a case manager who are not on that. They're on something else, or they're not even on MassHealth, right? So just know that this information and this new program only applies to people who are ACO, stands for Accountable Care Organization members. So you may, you know, later go, I went to this workshop and they said we were going to get this resource, but it's because your person is on OneCare. I'm just making that up. Or it's because your person's MassHealth coverage has lapsed. So just keep that in mind. What I will say, and Dave actually asked me to make sure y'all know, if you're working with somebody and you don't know what their coverage is, here's who you can call. How you can find out. You sit with your member or ask your member to do this, and they can call this number, which is kind of at the bottom there on the right side, and ask, what coverage do I have? Is it MassHealth Care Plus, Standard, Common Health, all these random things? And am I a member of an accountable care organization, and which one? Because I don't know, depending on who you're working with and what level of involvement they have in their healthcare, they may not have any clue. They may know who their doctor is. Yep, their doctor is always, you know, they'll say, oh, I go to Barry over at Boston Healthcare for the Homeless. I see Dr. Gata, right? But they have no idea who's paying for that, which is really what we're talking about. What their insurance is. And even then they may just say Tufts. Well, you know what? Tufts has a OneCare product, a Senior Care Options product, and I think 5 different ACO products. So it's really important as you start thinking about this and hearing about accountable care organizations that as you work with people that you are finding out exactly what type of coverage they have. And this is the best way to do it. You can't call for somebody unless you have, I think, some sort of healthcare proxy. This actually has to be the person themselves. You can be sitting next to them. But the person themselves really needs to make the phone call. Any thoughts? Am I talking too fast? Okay, I'm going to turn this over to MassHealth folks now, and you're going to hear from them. They'll tell you all about the accountable care organization, what we call flexible services, which is the new program, sometimes called Flex, sometimes called FS or FSP. Just, you know, depends. And just so you know, another acronym that's going to come at you is SSO, Social Service Organization. It's just anybody who provides social services. MassHealth came up with a new acronym. And the first thing I think I said to Stephanie when we met is, the SSOs don't know they're SSOs, you know. You just made that up. So just know that some of these things I may jump up and say, oh, SSOs, that's all of you. And it could be any of you kind of thing. So I'm going to turn this over to Max and Stephanie. Somebody coming up here? Okay, sure. Do you need a clicker? I think I do. Okay, great.
Good morning. Thank you so much for having me today. I'm really excited. I'm a little nervous. Usually I'm in a room of ACO members and I know I'm the person who knows the most about housing. And so now I'm like, I read evicted. I talk to Emily all the time. Don't blame me when I say something wrong. I sort of get it. So yes, we're working on this partnership, and this is a very first step, a pilot of marrying these worlds together. And I've been very lucky working with Emily, with Lynn, with all the folks at DHCD and MassHousing to get a window into this world. I started my work in healthcare and really thinking about patient advocacy and like, oh, the big bad hospitals, the big bad health insurance. Like, we have to get these people coverage. Like, you think about like every like legal aid person. Technically, I'm a lawyer, so hold it against me. And so when I started working on this housing stuff, it really fit right into that world. So I'm really honored to be able to do some of this work, and I'm sure you'll be able to tell me how we're doing it wrong, and we could hopefully work to overcome those barriers. So I'm going to try to give a start of an overview here, and then my colleague is going to tell the more interesting things about the services and who's eligible, and then I'll come back and do some more boring operational stuff, in which time you'll tell me, oh my goodness, but we'll try to break it down. So I lead the Flexible Service Initiative here at MassHealth, and so yeah, we'll just jump right in. So we're going to talk about Flex, but I'm going to take it back a couple of notches because this is also sort of a 101, a larger 101 for folks. So where are we in the quote unquote healthcare system as opposed to the public health system? We are working on this whole payment reform initiative in which we are moving from a model in which we paid a doctor every time they performed a service, called fee-for-service sometimes, to a member, to this overall, you are accountable, so to speak, both for your quality and your cost of your overall member population into this type of accountable care organization. And we get that this is a hard process and that this looks at a whole person. And therefore, we're going to do a lot of work to partner in different realms. So we've already kicked off for the past number of years work with BH, behavioral health, and long-term services and support providers to work with them on those really high-risk BH or LTSS population to help them partner with. And we actually procured a number of entities to work with our accountable care organizations on these folks. We call those entities community partners. That's why we don't call you community partners, because why not make it confusing? So from there, that's one end of the spectrum. So we have physical health, we have behavioral health, we have long-term service and support. What we're missing and what we're adding in with this flexible service section is this health-related social needs, this public health need. When you look at the member, you can do everything you want, but in the housing first model, nobody's going to the doctor if they need to go get food, and no one's going to the doctor if they need to go to their job, those types of things. So we got approval through the federal government, through the Center for Medicare and Medicaid Services for this type of program, flexible services. It's a pot of $149 million, which is supposed to be spent over 5 years, but because it took us 2 years of negotiation over 3 years, so from 2020 through 2022, on this program. And it essentially means that now certain individuals that are in ACOs, that are MassHealth members, that meet the criteria that we're going to talk about, could potentially get housing support services and or nutrition support services. And we'll talk about what that means. So really quickly, we just talked about this, but again, what is an ACO? An ACO is a provider-led health plan. So we're saying, we tried this whole experiment of pay each member. We tried this whole experiment of health plans manage everything. Both didn't work out so well. So now let's try the provider and the health plan work together to manage the member. And by the way, it's not just about cost, it's about quality. And so there's 17 of these ACOs across the state. They started about a year ago, and they encompass about 875,000 members. And it's really about working with your PCP one-on-one, as well as the rest of the system, to have whole person centered care. Okay, so the last thing I'll say to you before I send it off to Max is that where we were, where we're going, and sort of our approach to flexible services in a timeline sort of fashion. And I would also say, don't let this timeline scare you. So back in October, we got approval, and then we realized, great, this is really exciting, but we essentially have 3 years left of dollars, so we need to move now. So what we've been doing since then is a lot of a roadshow and a lot of stakeholder engagement to finish up our policy making. And we had a larger convening of all social service organizations to come back in February to give a very similar presentation back then, in hopes of getting people starting to think about that. And so we wanted to also make sure we're doing specific to housing as well. What we're looking on in the near future, we're targeting about mid-June, is what we call guidance documents. So long documents that give more particulars about the program that you'll hear from today. But what I continue to tell providers, medical, social service organizations is, what we're telling you is the bulk of what you need to know. And so that really we're asking you to get out there now to have these conversations. We're giving you a list of the ACOs and their contact numbers. For most of these are direct contacts to the person that runs the flexible service program. Some are a little bit broader. We ask for permission from the ACOs to give these numbers. Likewise, we've been telling the ACOs in the Housing 101s, like, here's the local housing authorities, here's all the folks that are local housing authorities, and here's the numbers. So when you start to get calls, or if you're the city of Boston or anywhere else where you're getting calls, we're trying to educate you today on what people are talking about when they say we want to partner with you on flexible services. So we are trying for a January 1 launch. And what I say to ACOs and what I want to really echo to SSOs is we are doing a conservative ramp up. We've done some other projects like this, and it's a lot of work. It's a lot of work to marry two different worlds and then to contract with them and to deal with data sharing and all things that Emily's going to talk about. So while we launch on January 1, we don't actually expect a massive influx on January 1. We expect that there will be initial partnerships happening, possibly one per ACO, and that over time, over the first year and a half, the additional partnerships will start to happen because it just takes longer to do this work. And so I try to message that a lot because there's concern about what people are seeing right now, how much reach out is happening. It's because of this conservative approach that we specifically said to ACOs that that's okay, which is often not the case. But for this program, we're really messaging, do it right. Take the time that's needed to create partnerships that can be sustainable. Okay, I'm going to turn it over to Max, but any questions on just those slides? I'm going to expect that you perfectly understand ACOs now.
All right, thank you so much, Stephanie. My name is Max Blumenthal. I work with Stephanie at MassHealth on the flexible service team, and I'm really excited to talk to you today a little bit more specifically about what are some of the approved services that we are going to be authorizing the hospitals, the ACOs, to pay for with these flexible service dollars that we will be distributing to them. We'll talk about the disallowable uses as well as the eligibility criteria for the members to be able to receive some of these services. And I'm going to give you in the slides, and what I'll show you up here, we have all of the allowable services as well as all of the disallowable services. We're not going to go through them all one by one, but this is just to give you all an idea of what is allowable within the different categories of support services, and then you can kind of go back and peruse this more specifically to think about how it relates to the specific services your organization may provide and the folks that you serve as well. So the first category, and generally we've been thinking about these support services in two domains. As Stephanie mentioned, we have housing support services and nutrition support services. Within the housing support services, we've broken them down into pre-tenancy supports, tenancy sustaining supports, transitional support services, as well as home modification. So we'll go through what each of those mean and how we've defined them specifically, and kind of we can start get you thinking a little bit more about how you can actually start using these dollars to start to put some of these services into action. So the first category is the pre-tenancy support services. And those include things like assisting the member with housing search, budgeting, housing applications, as well as transportation to any of those services. And so you can see, you know, it's things like assisting the member with understanding their rights and obligations as a tenant, you know, talking to them about what their housing preference is, you know, a lot of the work that's kind of required to help somebody get ready to, you know, be housed, especially if there's somebody who's chronically homeless or, you know, somebody who's just transitioning or maybe has spent a short time being homeless. The transitional services are also included on this slide as well, even though we are generally thinking about them as a separate category. And those are things that we're really excited about because those go beyond some of the traditional services that a lot of organizations provide and actually start getting into the goods. And so with the transitional services, we can actually help, the ACOs will be actually able to give members or organizations money to pay for first month's rent, security deposit, costs for filing applications, costs for obtaining and correcting needed documentation. So that could be things like clearing quarries or the like. It can also go towards purchase of household furnishings needed to establish community-based tenancy. And so that also includes things like utility, deposits, and a number of other goods that, you know, that we're going to kind of allow at the discretion of the ACO to put in their plan per MassHealth approval. The one thing I do want to note as we start to go through all of these long lists is we have all of these services approved in the protocol that was kind of our contract in which we negotiated with the Center for Medicare and Medicaid Services. But the ACOs are going to have a lot of discretion to decide which ones of these services they actually want to target. They're going to have a lot of discretion to identify which target population they want to serve within the broader ACO members within the folks that they serve. And they're going to have discretion to decide which ones of these services they want to specifically leverage to target the health need that they've identified in that target population. So just because all of these services are allowable does not necessarily mean that each ACO is going to be paying for all of these services. Joe.
Just one clarifying question.
Hold on.
I'll give you a mic.
We could probably give a mic, yeah, because we got webinar people. So if you have questions, where's Dan? Where's Dave? He can be my other wife. You have to speak into the mic.
Is it on? No, it's red.
It should be on. No, I think it's on.
Okay.
Given the level of the broad discretion that you're discussing, that discretion is so broad that a particular ACO, if they so choose, would not have to partner with any SSO. Is that correct?
Do you want to table that for? We're gonna talk about whether or not how that works.
Yeah, let's table that because we're going to get into the actual operations afterwards. But it is a good question.
I'm going to also encourage actually maybe let's let Max get through all of the flex services. I can imagine people doing like, is this eligible? Is that eligible? Is this eligible?
Yeah.
So why don't you get through all of those and
All right, great. So let's go to the next category, which is the tenancy sustaining support. And those include things such as, assisting really just a broad array of services that help a member stay in their home. So that could be assisting the member with communications with their landlord, helping them obtain and maintain entitlement benefits. That's correct.
You're up top.
Thank you so much. Yeah. The last one I want to point out on this slide is that we also do have assisting the member with transportation to any of these tenancy sustaining support services as needed. The last housing category is home modification. And so those consist of things that are designed to help the member stay in their home and ensure the member's health, welfare, and safety to be able to function independently. So we've included a list here. This should be considered, including but not limited to. And so we have things here like the installation of grab bars, doorway modifications, HEPA filters, vacuum cleaners, refrigerators needed to keep medicines like insulin refrigerated, air conditioning units, track lights, as well. And this is, again, like I said, should not be considered exhaustive. The next is the nutrition sustaining support services, which I'll go through somewhat more quickly because I know it's not super relevant to a lot of the folks in the room. But the idea behind the nutrition, the services in the nutrition domain is really focused on providing the member with access to food to address any sort of nutritional deficiency or food insecurity. So that includes things like home delivered meals, medically tailored meals, helping members sign up for discretionary entitlement benefits like SNAP or WIC, could be including things like providing or assisting with nutrition education and skills development. Again, transportation to any of these services is allowable. Helping the member obtain household supplies needed to meet their dietary needs is allowable. And then again, we have a pretty broad catch-all at the bottom, which just includes helping the member get access to food. So that encompasses things like managing food prescriptions, partnering with food pantries, payment for any services related to helping the member get access to food that's needed to help their nutritional needs. The next several slides are all of the disallowable uses, again, which we pulled directly from our kind of guiding document, which is the protocol which we've agreed to with CMS. I'm not going to go through all of these specifically. Again, these are for you to look at. I do want to highlight a couple that are specific to housing. So one of them is ongoing rent or mortgage payments. So we are allowing, as part of the transitional assistance category, the payment for first month's rent and security deposit, but ongoing rent or helping folks with rent kind of in certain circumstances that are not transitioning into new housing is not allowable. Again, ongoing utility payments, payment for things like cable or television or internet, also not allowable. Again, I'm going to flip through these relatively quickly. You can look at these more specifically, and we're also happy to answer any questions about this. And then just the last one is, this is more disallowable services.
Can I jump up?
Yes, go for it.
Okay, so I want to, if you go back a slide, I want to, one more. Want to flag for you guys what's not allowed is duplication. Okay, so if your agency currently provides that services to that member, you can't then also provide flex services. So you can marry things. So if your agency does housing search, but you have no money for some of those transition costs like furnishings, you could marry them, but you can't do housing search that your agency is funded by somebody else to do and housing search that the ACO is going to fund you for. You could, yes, go ahead. Just say your name though, Joe.
Joe Finn with the Massachusetts Housing and Shelter Alliance. But just a clarifying question is that when you say if you're doing something else or being funded by somebody else, you're talking solely about public resources?
I am talking about services that a member is eligible to receive from another state agency and services that a member is eligible for and able to receive from a publicly funded program.
So if you have entities that are out there who are presently doing this, but
With
they're doing it through
philanthropy.
private philanthropy, they certainly could be tied in.
Yeah, those kinds of things. So I think no, yeah, I agree. It's not the same. The idea, right, is that CMS doesn't want to pay for something that another agency is already paying for. So we actually see this as a good opportunity to enable more funds to come through for members, our members, your clients or consumers, where it is needed. So our favorite example is CSP for the chronically homeless, or lovingly referred to as CSPEC, where you may be paid for the service through the MassHealth benefit, but can't get these goods, right? So you could marry them in that way. Another way you could do it is you could say, well, I have first month rent through RAFT or home-based, but I want so much more than that. So I work with an ACO and say, we only have $100,000. Do you want to make it $200,000? So it's not, I do it now, I can't do it more. It's what I do already for public service. I can't just do it and get full dollars.
But
We're not going to pay you doubly.
But this is kind of where it gets a little bit confusing, because when you take a product like RAFT, it is already so far oversubscribed. So you're not saying that if they can't get it through that, just because RAFT is doing it, doesn't mean you can't necessarily.
So I want to flag the part of the bullet that says recognizing that certain public programs periodically run out of funds. So if RAFT, for example, you're an agency that administers RAFT and it's 6 months through the year and your RAFT benefits are gone, if you had a contract with an ACO and you are serving their ACO members, now I'm saying this is Elder Affairs, and I keep looking at Stephanie because MassHealth is the people who make the rules, not me. I just translate. If you run out of funds, but you have a deal with your ACO and a contract with them to do RAFT-like things, as long as they're eligible, not all RAFT-like things are eligible, that they could say, we're going to send you our ACO members, and you could continue to provide that service because there is no funding left for it.
Yeah.
So it's one of the reasons that we're thinking of talking to you all about this, and that ACOs are thinking of coming to you, is they have no idea what services are out there already. So you are much more equipped at knowing, okay, well, there's RAFT and there's home-based and there's CSPEC and there's, I'm just throwing a tenancy preservation program, whatever it is, and this one runs out of money, and this one I could do more of, but ACO members aren't going to be eligible for because of program eligibility, or this one I just don't have enough staff for. So I think you should be thinking about strategically at your organization where there are gaps and where these eligible services would fit in to meet those gaps. Tom, in the back. Tom, do you want to say?
You may have just answered it, but just to make sure. So in some agencies, you've got a case management function, for example, and they do housing search. So you could say that we already have people doing that, but my prejudice would be that housing search is best done with dedicated staff, for example. So if you wanted to break those two things out and say one public source is going to pay for case management, but we're going to take the housing search function off of case management and make it a separate thing funded through flex funds.
Yeah, I'm going to let Stephanie answer that, but I think the devil's in the details with that one. But the concept of having an ACO kind of buy a staff member at your agency to do non-duplicative things is something that we have discussed and I think would be workable. But I think there's a lot of details in that question. You had a question here?
Yeah, this is a similar question. Corey Yang from the Community Action Programs. So if we're braiding funding, and we have multiple sources that are funding tenancy preservation, but our state source, which is, we appreciate, doesn't fund us to serve the number of units we want to serve through this particular initiative. So we could leverage this additional funding, despite already receiving money for tenancy preservation, if that tenancy preservation only funds up to a certain number of units. Is that correct?
You would have to first, I think, go through the exercise of making sure you're not already serving the ACO members.
Yeah.
And then if there are ACO members being referred to your organization because you have a deal with them, then that might be something. Stephanie?
Yeah, I mean, if you're talking about like, okay, you have $1,000 and that gets you 1 unit, 2 units, right? And now you need 4 more first or last month rent security deposit units. Well, the other money's run out, right? So as long as all of the caveats, you're serving the ACO member, it's just all into the plan, all those things, yes, in theory, that's how it would work with sort of the case management, housing search and placement. If you are given $100,000 to do housing search and placement from DHCD, you can't say, well, now I'm going to double pay. You would just say, now I can serve double the amount. But again, it's sort of, and we'll talk about this later, funnels through. You have a relationship with the ACO, and the ACO says, these are my MassHealth members, and when they come in the door, or when I send them to you, that's who's getting those dollars. It's not a grant pot of money to serve like any member that comes in the door, if that makes sense.
So I'm going to encourage us to just move ahead. I think this is going to flesh out as we keep talking, and if not, we'll keep talking about it.
Okay, great. Thank you so much for the questions. And again, we'll have lots more time to answer at the end. The next topic that I want to move to is the eligibility criteria, which we've kind of started to talk about already. And the first one is that they have to be in a MassHealth ACO. So again, Emily kind of laid out that there are a number of different MassHealth products. But in order to be eligible for the flexible service program, the first kind of important box that they need to check is that they have to be enrolled in a MassHealth ACO. Again, there are 17 different ACOs. They serve around 800,000 members across the state. And we provided you with a list of all the different names of the ACOs and kind of who their contact people are. The second bucket that they'll have to check is they have to be screened positive for at least one of the following. And those are behavioral health need, a complex physical health need, assistance with one or more ADL or IADLs, repeated ED use, or pregnancy with the high-risk complications. And we'll, in subsequent slides, talk a little bit more about this. We'll provide you with specific definitions of what we're thinking about for each one of those health need-based criteria. The third category of eligibility is a risk factor. And so they must check at least one of the following, and that is either homeless, at risk for homelessness, or at risk for nutritional deficiency or imbalance. And I want to emphasize that we really tried to think pretty broad with these eligibility categories, and we'll also, with the risk factors, go into kind of the definitions that we're going to be using to help kind of guide the eligibility criteria for each one of these risk factors. But again, we wanted to be kind of as broad as possible, again, recognizing the fact that ACOs are going to have the discretion to decide of these kind of needs-based criteria and of these risk factors, what target population they want to focus on and which services they want to provide within the eligible services that we've covered. So I'm going to move to just give a little bit more specific information about the health needs-based criteria. And again, this is the specific language that we use at MassHealth. And so the first one is the behavioral health need. And so that's a behavioral health need that is requiring improvement, stabilization, or prevention of deterioration or functioning. So that includes the ability of the individual to live without support. Similar for the complex physical health need, again, we're not, talking about any sort of specific diagnoses. That's going to be up to the discretion of the ACO. But again, it's a complex physical health need, which is defined as persistent, disabling, or progressively life-threatening health condition, again, requiring improvement or stabilization or prevention. The individual is assessed to have the, needing assistance with activities of daily living or the independent activities of daily living. Again, we tried to keep these pretty consistent with the definitions that exist out in the world. Again, repeated emergency department use and pregnant women, including 60 days postpartum, and their children up to 1 year who experience high-risk pregnancy or complications associated with pregnancy. So again, these health needs-based criteria are designed to be pretty broad. I think, you'll find that, members who, are going to qualify for this program via one of the risk factors, either homelessness or risk for homelessness, are likely going to be able to check one of these boxes.
So Max, I'm going to jump in just at actually the first line of the slide, which is ACO enrolled MassHealth members ages 0 to 64. So this is for children as well, not for people over 65. They cannot also be enrolled in Medicare. Sometimes those people are called duals. And they can't be on some of those other programs, not all of them, but some of those other programs like ACE or One Care that I showed you on the first slide. So not everybody is going to be, even though I wrote down the number again, 900,000, I don't know. A huge number of people are on the ACO. Still, there are some people who will not be eligible for ACO. So I just want to make sure that ACO enrolled MassHealth members ages 0 to 64 who are not on Medicare and not enrolled in some other MassHealth program. So we're kind of funneling a little bit.
And the last thing I want to note on this slide is that we are not requiring that the actual services that the member receives be specifically tied to the health need-based criteria that they are assessed for. So you could have somebody who's assessed for hypertension and is at risk for chronic homelessness, and you want to give them pre-tenancy support. So again, their hypertension is not necessarily directly tied to the housing intervention that you're going to be providing them.
What does it look like for someone to be assessed for a qualifying health needs-based criteria and then receive those services 6 months, 9 months, a year later? But I'm thinking in the category of pregnant women, 60 days postpartum, they qualify, but they don't receive the service so much later.
We can talk about it when we get to that.
Yeah, so we'll, I'd say all of those kind of, the screening, the planning, and actual service delivery, all that is in active policy development right now. But when Stephanie gets to the final section of our presentation, which talks more about some of our operational policies for how the ACOs and their partners are going to be thinking about actually putting this into practice, she'll get into some more of those details. But I mean, it's a really good question. Joe.
This is, again, just so it's clarified, right, is that the lists that are going to be coming about those who can be served by these flex funds, those lists essentially as it stands, really, those assessments are determined through the ACO.
Yeah, that's correct.
Yeah, I think they're gonna cover that in a couple of slides.
Yeah, the actual screening of the screening of the members for these eligibility criteria will be done.
I can safely here say that nobody needs to start learning what an ADL is if you don't know what an ADL is. Right?
So just diving in a little bit more specifically into the risk factors. So the 3 risk factors I mentioned previously are that the member is either homeless, the member is at risk for homelessness, or the member is at risk for nutritional deficiency or nutritional imbalance due to food insecurity. And regards to the risk factor, we do expect that the support service that the member receives does tie to the risk factor that they screen positive for. So for example, if you have somebody who screens positive for nutrition imbalance or nutrition deficiency, they would not then be eligible to receive, first month's rent or security deposit unless they also screen positive for risk of homelessness or homelessness. So again, there's a lot of text on these slides. I'm not going to specifically read through these all. I'm going to let you read through them at your leisure time, but I do want to call out a few things so the first one is that the member is homeless. And again, this is the language that's taken directly out of the protocol that we use here at MassHealth. And, we really started with the HUD definition, but again, we want it to be as broad as possible. And so I'll just call out a couple of things here as you read through the slide. Again, it's, an individual whose primary nighttime residence is a public or private place that's not designed, for regular sleeping. It could be that they're living in a shelter. It could be that they're in an institution, but they meet some of these other risk factors. They could be at imminent loss of, they could be about to imminently lose their primary nighttime residence. They don't have the support structures. They have no other residence that has been identified for them.
And just to flash with my McKinney Vento Continuum of Care friends, I think the 21 days, I think it's now 14 for HUD homeless programs, and so this is broader. So, we really tried to mirror the HUD homelessness, but I think where MassHealth was able to go broader, they did. And just flagging like the little differences.
Yep, thank you. And again, this just continues the first risk factor. So we also include a member who is attempting to flee or is fleeing domestic violence, dating violence, sexual assault, stalking, or other dangerous or unsafe or life-threatening conditions, has no other residence, and again lacks the resources or support networks, to be able to find housing. The second risk factor is at risk for homelessness. So the member is defined at risk for homelessness by the following: so they do not have sufficient resources or support networks immediately available to prevent them from moving into an emergency shelter. They've moved because of economic reasons 2 or more times during the 60 days, is living in the home of another, is living in a hotel. Things like doubling up would make somebody eligible, and has a past history of receiving services in these publicly funded institutions or systems of care designed to support people experiencing homelessness. And then we have more definitions that will enable folks to be eligible under this member is at risk for homelessness criteria. So, it could be that the member is living in a household that is, unstable and is increasing their risk of homelessness. So their house is unhealthy, so it could have evidence of rodents, water leaks, peeling paint, poorly working smoke detectors, poor air quality. The housing could be inadequate due to, problems with the plumbing, heating, lack of running water, lack of working toilet, as well as rent arrears. And we include here that the missing 1 or more monthly rent payment, as well as situations such as receiving a notice to quit. So this is actually before actual eviction proceedings have started underway. And then the last one is the members at risk for nutritional deficiency. Again, we really tried to think as broadly as we could in terms of writing these. So, the member has nutritional deficiency or imbalance due to food insecurity, defined as having limited or uncertain ability of nutritionally adequate, medically appropriate, and or safe foods, and the limited ability to acquire these appropriate foods. So I'm going to pause for 1 second before I turn it back over to Stephanie.
We're actually going to keep going, I think.
Yeah.
And questions.
Yeah, that sounds great.
For folks online, we've been looking through your questions, and I've been feeding them to Stephanie, who's going to try and address some of them. Yep.
Okay, great. I'm going to turn it back over to Stephanie, and she'll talk more about the operations of how actually deliver these services will work.
Great, thank you. So I know there's a lot of questions on eligibility and services. We expect that. So we're going to hold most of those. I'm going to try. Those on the phone have been writing in. So if they have a question and they're confused, I figure you're confused. So we'll do some of those now while it's fresh, and then hold the ones that are operational, and we'll talk a little bit about it. So a few things. So I said when I said like tons of other things, this is a demonstration program. So it's exciting. We have $149 million, but it's only $149 million, if I ever thought I could say that. It's only after being at MassHealth. So that means it's not an entitlement program. It's not a new benefit. It doesn't mean that if you're in an ACO and you have an ACO member that fits some of these criteria, they automatically get it. No, this is like anything else that you guys deal with, that it could run out of it, but the ACO could decide to do something else. So I hate when I get to be that bearer, but it's something to remember. Other thing to think about is when we were working on this with CMS, our goal in life was to be as broad as possible. Get everyone in the overall door around the possibility in terms of health need. And I like to say, you know, it would be very hard pressed for a physician or a social worker, whoever is doing a screening or planning, not to get someone in the door on one of these health needs. Like, think broad, think creatively. That's what we tell our ACOs. It's a fairly low bar, but they do have to meet the need and get in the door. And then once they're in the door, we narrow from there as well. But there's a lot of different opportunities. The ACO has the opportunity to say, I want to work with pregnant women. I want to work with people with asthma. I want to work with behavioral health. And it is subject to our approval, but it could mean that your member is someone in an ACO that works on behavioral health, but they have a physical health need, and therefore that wouldn't match. So it's a lot of opportunities for innovation, but there's also areas where it narrows. And that also happens on the service side. So an ACO could decide that they want to do first and last month's rent, but they don't want to do moving costs. So again, a lot of opportunities, but there's an opportunity to narrow. And MassHealth, with our help from DHCD and from Emily and from others, are looking at those choices very critically to make sure they make sense. And the idea was that each population that an ACO works with needs something different. And so we're not ready to say it is absolutely this thing for all of Massachusetts. We want to see what everyone does and see how that works, the whole testing thing. So a few other points. We talked about this transitional service, and we're really psyched about this, and we really think there's an opportunity to really marry different benefits, the CSEC benefit, the EA system with some of these goods, but they are only available when you're transitioning into housing. So you're on the street, you're in a shelter, or you're moving from one housing unit or unit to another. That's when you get the opportunity. You don't have the opportunity if you're in housing month 2, month 3, and now you need a mattress. We can't help you there under transitional. Maybe under home mod, we can't give rent on it's the 3rd month and I know I can't pay the 4th month. It's only 1st and last month. So those are my one more sort of services before we take questions later on that. The other item we're sort of excited about is legal assistance, but it's pretty vague and it's a little bit blurry, so stay with me. You cannot have a lawyer represent you. That's not how the wording in our contract is. You can have essentially coaching, supporting, helping with legal needs. So that I kind of draw the line at. You couldn't have a lawyer come represent you at housing court, but they could probably sit next to you and tell you what to say. And they probably couldn't sign the letter for you and say, as the representative of so-and-so, but they could probably help you write the letter. So it's a little creativity, but we're still pretty excited about that opportunity. Let's see what else. So on the duplication, because I know we confused a lot of people there. So you guys are doing a lot of the work that's already here. You already know this stuff. It's your bread and butter. And that's what we're hoping to have you all do for us and work with our ACOs who don't do this every day. It is not a problem if your organization already does this work and wants to now do it more for ACOs. The problem is really how it's funded. So if it is funded through a public source, so through a federal or state agency is giving you money to do something, it's not that you can't do more of it with additional money. You can't just take that same dollar and add on top of it. So I now pay my social worker double because I have, CMS money. That's not going to fly. But you could add another person because now you can serve more people. And we'll talk about how that potentially could work. One other thing I think we've heard, so the ACOs are sort of like set. There's 17 of them throughout the state. We prepared them in a very long process about 2 years ago. you'll see the contact list that we gave you in the handouts, but right now it's not open for procurement, and we can talk a little bit more about a lot of the agencies and entities in this room might more likely be already associated with what we call a community partner than an ACO already, which means that you're one of these behavioral health or LTSS, long-term services and support organizations. And so you're working under one of those entities. We do have lists in the back of our handout of who the ACOs are and who are the CPs. And so you'll probably see some that you know. And if you go to our website, the CPs sort of have entities that work under them. So the main entity might be CP XYZ, and they have CP A, B, and C, D also working with them. So you'll be able to see if you sort of plug in there. Not to make life super confusing.
In the room, raise your hand if you work for a community partner agency. Nancy? All right, yeah. So we have a few in the room too, who wearing multiple hats.
Okay, let's get really confusing really quickly, but I'm going to try to break it down for you in this model. So what are we looking like? We said we have this bucket of money. MassHealth has this money. The idea is that we put flexibility in flex services. I cringe every time I say it, but that's the idea. And that MassHealth will give broad guidance, and broad guidance for us means a big guidance document. And then we filter it down to the ACOs to work with their communities to come up with these plans, right? And this is kind of what I was talking about with the conservative ramp up. So they'll create a plan and they'll create a budget, and we're encouraging them not to do it too quickly. So if you only know something about nutrition right now and you haven't found the right partner yet, you haven't done the talks yet with housing, don't just put something down. We would rather you do the work and come up with a partner and come back with us, you know, in 4 months and 6 months to make sure that you're actually sort of doing it right. Or if you want to start small, fine. Or if you happen to know a lot about housing or are working with some of these agencies, which some of our ACOs are, and are ready to expand, that's awesome too. But we want to keep messaging that. So the ACOs will receive their funding, and then they have this option to either work with a social service organization to deliver these services and goods, or to deliver it directly to their members. So they could either do the work internally or do it externally. MassHealth is not putting a direct, you have to go external. We are strongly encouraging it, and we've had a lot of questions on this, and I would say this about it. We spent a long time, and we have a whole sort of social service integration work group, which we call SWIG, which has a number of your folks on it, actually, Nancy. She represents for all of you, but no, no pressure. So there's a number of other institutions and larger agencies on there, as well as ACOs and CPs, and we talked to them about it and others. And when we talked to our ACOs, they named over like 100 social service organizations that they were interested in working with, which made us feel like we didn't have to lay down the hammer at that moment. What we will be doing is when we review plans, if they aren't working with external agencies, we're going to want to know why. It's going to have to really be a good reason. So if you tell me I want to build a food pantry and there's a food pantry down the block, I'm going to look at you really hard and be like, why are you building a food pantry? There's one down the block, right? We don't want to recreate the wheel. We're not looking to recreate the work of other agencies. What we're trying to do is help our members access those very needed health-related social needs. Yeah, sorry.
Sorry, Stephanie.
No problem.
So, I am Carrie Boston Health Care for Homeless, and this is wonderful, and I'm really grateful that MassHealth has moved in this direction. The thing that I worry about is exactly what you just said, and you know, because the ACOs are not mandated to contract, they can build all of this internally, so they don't have to contract. And having to wear a CP in my program, it's an enormous amount of work to contract with all of the ACOs. When you talk about 100 SSOs, the ACOs are not going to contract with 100 SSOs, and so they're going to really want to narrow that pool. So I think for those of us in the room, you have to be thinking today strategically about, do you do this through a partner, community partner, that you may have some connection to, or start figuring out how to begin to contract with the ACOs. And Stephanie and I were in a meeting together yesterday, it's also favorite. And I think MassHealth does have a greater responsibility to hold the ACOs accountable, because I know that some of the ACOs have already talked about the fact that it's just too hard to try to figure out how to work in the community. It's much easier to build all of this infrastructure, and it doesn't make sense when there are all these amazing organizations with their history.
I won't answer for MassHealth, Barry. I think you're spot on, and I think at the end of this, sort of as the takeaways, I think are also, to think about your agency and where you want to position yourself in this. We're trying to lay out the landscape, how MassHealth gets involved in it or not, but I want to make sure you have all the information so that your agency can think about how best to proceed when, we're giving out your number to them, like we're giving out their number to you. So whatever I just said, but people are going to be calling you and going to say, oh, I hear you do X, Y, or Z. Let's talk, and just making sure, what does that mean? And you've thought about it a bit.
Can you take one more? Yep, go ahead.
Go ahead. No.
Hi, Craig Keith from the Arbor Hospital in Jamaica Plain, and the ACOs are now they call me daily when patients arrive in our facility. And, we're one of the biggest behavioral health providers in Massachusetts for MassHealth clients, and most of them are checking off all three of those columns. And so when they're going back out to the ACOs, my biggest worry is very similar. It's really a distribution of services. That $100-something million is going to go quick, very quick. And so as the ACOs see that and they're providing internally, that's my biggest worry as well, where my 18 social workers are calling. I'm going to go back and train them, call these ACOs. I don't want them to necessarily be wasting their time. So there really has to be a streamline around it. That's my worry. And I have one other just quick question. So after the 3 years, if this is a success, will it continue to be, I'm sure you might talk about that, because 3 years is very quick period of time to invest in it, and these resources may go before the 3 years if it's run efficiently and well, and it's used. So that's also just a couple of my talking points questions.
Yeah, they're all good points, and none of which don't keep me up at night, I promise you. So I think to the issue, as I said,
That's
about...
what I was going for, by the way.
Yeah, I mean, you can call me at any hour. Ask Emily.
She must be kind of
it's like 3:30 a.m. and I'm like, it's too early? It's fine. Emily's like, yeah,
we have a question that I'm hoping you can easily put to bed, which is, can a community partner agency be an SSO?
Absolutely.
In this scenario that you have online?
So I'll answer this one first. So if you're a community partner, you would take off your community partner hat and you would put back on your SSO hat, and that's how you would be delivering services, right? So the answer is yes, you just wouldn't be in your official community partner role. You would be in your SSO role. In terms of the concerns on the buy versus build, as we call it, internal versus external, again, I think we'll see. Like I said before, I think that the initial plans that we see will be conservative. So I don't think we will see, nor will I take it as a mark of concern if I don't see 20 social service organizations on the first go around, because I think people are trying to say, we're just learning about this. We're giving them 7 weeks to put together a basic plan. And so that's not a lot of time to do a lot of this work. So it's going to take time. And then as we see it progress, that's when, if we need to be stronger, we'll be stronger. Echoing what Barry heard yesterday. And our leadership hears this. This comment came up yesterday at our leadership. So we're on it as best as we feel that we should be in it. As far as sustainability, so we can talk a little bit about evaluation plans. I think we are trying very hard to figure out, we have a whole evaluation, and then we have creativity around different ways we are thinking about evaluating flexible services to then see what's next. And that's a really quick overview of we have an evaluation and we have to see what happens with it. All right, I'm going to move on. So I always get a little bit wary of showing this slide, but we think it's important, and I put a lot of caveats in this slide. So I say first, like, this is not a member journey. Our social service integration work group made that very clear. We would never want, or we would never be able to keep a member if they had to go through all of these steps one by one by one by one. What this is an operational workflow from an ACO perspective. So with $149 million comes some level of operations and some level of requirements from federal and state government in order for us to evaluate if this works. And one of the questions of whether or not this works is, does it work in the healthcare world, which does have this level of operational existence in it. So it's important to know about this. It's also important to know about it because an ACO can designate this work, can contract with a social service organization to say, listen, I think you guys, do you want to do the screening work and come into a contract with you to do that work? So it's good to know in case that's something you're thinking about. Everything before delivery and really also the feedback loop, we consider administrative or operational and is not within that $149 million. So that money for ACOs, they can use other admin dollars that they receive from us, or they receive other money from this demonstration, which we call startup and ongoing, so essentially implementation dollars to do this. And that would be one of the ways they could contract with you. I will walk through it sort of really quickly, step by step. There is a lot of nuance in here. I'm not going to try to do it all today. There will be released more information that's much more substantial on this information. And I would say we are working with our work group to do things that are more member-centric journeys on how you would condense this. For instance, take screening, planning, approval, navigation, right to delivery, all in a visit. It obviously cannot be one visit, two visits. You never find the member again. We get that. But think operations. So first, the member identification. So I think the most normal call you'll get right now is ACOs trying to figure out where their members are, who's homeless. So they know somewhat in their data, but they sort of know from us that you know more. So you might get conversations, and Emily will talk more about this, about data sharing. They are now aware of this world of like, oh, there's this thing, it's called chronic homelessness, and there's lists, and there's a data system. This is all very new to them, just like that's new to you. And they're like, ooh, data. This is all member identification world, and Emily will talk more about this. And there's that actual outreach to the member. So, but really I'll focus for a few seconds on screening and planning. And this is broad screening and planning. This is not the process by which you sit down and assess the member's needs for housing. This is, do you meet the risk factor? So for example, really high level, where did you stay last night, right? That's an often question that ACOs use that could potentially, and that you all use, that could potentially check a box on a risk factor in screening. So it's meant to be quick, and it's meant to just be a quick entry into the system. We purposely do not say it's an assessment. The plan is also not your like housing plan. It is the generalized plan of what the member needs. Did we assess the need as nutritional deficiency, and therefore they need nutritional services? And are they not enrolled in SNAP? So we need SNAP. Similarly, on the housing side, did we assess the need as, housing insecure because they have, infestations, bed bugs, whatever you want. So they need a mattress. They need, extermination, that type of thing. And so it would be broad level and then narrow as you work with your SSOs, if that makes sense. Approval, we have left it pretty vague. So there's a lot of ways to do this program because, again, we think it's an experiment. So one way an ACO could say is that they could say, SSO, we know you're doing, you know what you're doing, and so we want to work with members who are pregnant and who are homeless. When they come to you, and if there are members, you don't need to check with us. Here's the lump sum of funding. Tell us on the back end. So that's one thing, and we get that question from ACOs all the time. On the other extreme and everything in between, they could say, come to us and get approval first if you're the designee, or the actual person in the ACO that wrote up the plan has to go to like a higher level person and say, is this okay? So that's approval, then navigation, and then actual delivery of services. The feedback loop, which is one where you may be more involved with, is the connection back, right? What we don't want anymore is for ACOs just to refer them down to housing shelter X, right? We want them to know what happened to their member. Did their member get housed, or are they still in the street? Because that's the idea of whole person care. And so we're closing that feedback loop. Okay, so who can perform flexible services? We are not, I think I said this before, procuring a list of social service organizations. So there's not one list out there, nor do you need to apply as a housing organization to be a social service organization. What we are saying is there are particular individuals in your organizations and agencies that can provide flexible services. And it's broad, and we made it broad because we could be talking about a plumber installing a grab bar, and we could be talking about a social worker doing housing search and placement, a lawyer working in housing court. So it's pretty much, again, these two boxes, check one, and it's, do you have the education and do you have the skills? And it's broad. So funding. So we've talked about this a bit, and I'll wrap it up with here. So the funding comes through to the ACOs. The way that we determine what ACO gets what is based on their member count. So the larger the ACO, the more members they have, the more dollars they receive. They will, once they submit and get approved their budget and plan, they will get a quarterly payment, and the quarterly payments break down over the years. And it's sort of a different chunk of money each year because we have to follow some rules about how the money flows. For ACOs, the money can only be spent on the actual service. I said really quickly before, we give ACOs a ton of other money. That's where their admin costs can come in. For an SSO, so for all of you delivering services, your admin should be baked in. Emily will say this, but like you should give them a full baked in rate, right? It shouldn't be like, oh, and this for this, this for this. You should think about all of those admin and infrastructure needs and say, this is my rate to give you this service. Trying to see if I'm missing anything. I think that's generally where we are.
I think to go back a second, I think MassHealth is not getting involved in negotiating the relationships between the ACOs and the SSOs. So they will approve kind of eligible use of the funding, but they're not going to say, okay, you know, the billing arrangement or, you know, how often people are compensated or anything like that. They're not, you know, I just want to see at the bottom it says ACOs and entities that ultimately deliver flex services will negotiate payment agreements, whether it be prospective, fee for service, bundling. I think MassHealth is pretty clear that they're not going to get in the middle of that.
Yep. And Nancy can tell us everything we need to know about the different payment structures. Right?
I also want to
hard on it for
call out, Stephanie, that nobody has any flex services money until January 2020. They have other ACO money, but the conversations they're having with you right now are not going to probably net you flex services money until they get some in January 2020. So we are almost in May. Their plans are due to MassHealth somewhere. The guidance will come out in June. Plans are due somewhere this summer. And then it's sort of operationalizing that in the fall to start with a conservative approach in January of 2020.
I'll go back over there so I can see some of it.
So most of the questions that have come in, Stephanie, online have been about, is this person eligible? How do I find out if the person is eligible? Like, what is the behavioral health or substance use? How is that determined? Would a person who, for example, is medically frail and living in a walk-up unit, so there's questions about who is eligible with those criteria, but then there's a lot of questions about eligible services. Is a CSA membership eligible under nutrition? Is a congregate meals in a congregate setting? So I don't know if you want to get into all of those or if you have a mechanism by which those can be answered by MassHealth. Because there's always everybody, those are where the devil hits where the rubber hits the road, but I don't want to spend all time today going into those level of nuance.
Yeah, I'll say that. Like generally, so I don't know if we put it on these slides. So we have, and if not, we can send it out afterwards. We have a flexible service inbox where we are taking a lot of these questions right now, and they're sort of like, I have a member and they look like X and they need Y. Will that be allowable, right? And I'll tell you, we'll intake the information at this point, and we're essentially gathering it to make sure where it comes up a lot, we put it in guidance, and where it isn't, we will wait for the ACO to submit the plan. And the reason for that is, as you saw, there's a lot that could happen here. You know, a complex physical health need is pretty much everything. So it's hard to say which will be eligible. What will happen is the ACO will work to determine their plan, will determine ultimately if broadly, given everything in their plan, if it's okay and once approved, and then that's what's available for that member in that ACO. So that's why I said it's hard and it's narrow, because while it's a great opportunity for innovation, it's not the same across the board. So you could have an ACO on one side of the street treating pregnant women for homelessness, and an ACO on the other side of the street treating BH members for nutrition. And so that is kind of, we see it as an opportunity for innovation, but we recognize the hardship in there's a lot of different opportunities out there. Right now, because we don't have the plans and we didn't approve them, we don't know what it will be, but we can talk generally for you about things like moving costs, things like query fees, things like application costs. Yes, they're all allowable. Whether or not they come into realization is a question as we see the ACOs. And I think when you talk to your ACOs, they're really looking for ideas. They ask Emily, like, what do you think we should do, right? They want to know, and part of your value is to explain, I see members, I see our consumers do well with this. I've seen success here, and they want to know that. I'm really heartened with our ACOs knowing what they don't know and being willing to say where I need to reach out. And I think that's what we're seeing on our calls. Emily and I have done a round robin of calls with all the ACOs, and I think all of them say, Emily, as a housing expert, what would you do? So you could all put it on Emily.
Like keep making me queen for the day or something.
Yeah. So I think that's one of the really areas of value that you bring to the table, and Emily will kind of go more into that.
So I have two specific questions. Maybe you could answer, Stephanie, and then we'll take questions in the room. Ken, on this slide that we have up here, can experience substitute for education? So it looks like they have to have the education.
So it's at least 1 year of relevant professional experience. So we get that not everybody in the world has a bachelor's degree in XYZ, but to us, education also means you've learned in the field, and that's why it's like education / experience.
So it's you don't have to have all of those check marks.
No, check one box.
Okay.
Sorry, I keep asking them.
And then there's a question, is a member in a CP also eligible for flex services support?
Yes.
Okay. And I think many of the other questions, if people online, we have been looking at your questions and we've been trying to triage them. I think some of them are very specific. So we are going to get a list of all the questions that are submitted. And as I said, we have a registration. So we have your email. So as guidance is put out there, that is public and sort of everybody across the board, then we'll make sure that gets to you as well. Are there questions in the room? Yes. Hey, Amy.
Hi, Amy Slightly, DHCD Public Housing. I don't see housing authorities in the room. Maybe they're on the phone, but this would be very new for them. So the question is, I was hoping the ACOs knew where their people were, but you're saying they kind of don't. So who's going to outreach to whom if they're not a CP and they already have those relationships? If you're new to this game, do you reach to the ACO, or is the ACO going to know they should reach to you?
So I think,
I just want to add one thing. So,
yeah, good.
but the data, so Emily can talk about data. So they have data, right? So the way that it works in claims world with MassHealth, and I'll speak just briefly to this other thing that's happening for claims data. But so you can, and Barry, you can also keep me honest, and Emily can keep me honest. You can sort of put in a person as homeless into your system. It's called an ICD-10 code of V59. And so if you're doing that, that will now, like when you do your algorithm, pop up a list. We also do it based on if you've had 3 or more addresses in a year. So it's not a perfect system, we recognize that. What we are doing to encourage this, and what we are doing as a recognition, within the MassHealth rate, a number of things are thought about, right? Because you could say, you could be BMC that sees a lot of the underserved, and you could be another population that might not serve those folks. So we do what's called risk adjustment on the rate. One of the things that we're doing now is if you are homeless, your risk adjustment score changes, which means if you're serving more homeless members, in essence, you could get more in your rate. So providers are really now, I always like unplugging V59, right? Like make sure you code for it, but it's sort of new, so their lists aren't so good.
But Amy, I think to your point, they have a list of members and the addresses that are in the system. When I met with them, the ACOs on Tuesday, I encouraged them to look at their system and see if the people clumped in any way. And I think they're already thinking about that. They'll say, we have a lot of members in Lowell, or we have a lot of members in this. I don't think they've gotten to the address level yet. But we did hear from one ACO that they have been thinking about maybe they put a person in a housing authority building. This is an ACO that already has a relationship with the housing authority. Because as far as tenant stabilization. And in that case, we have to make sure they're not duplicating any service coordinator or any of that kind of stuff. But I think thinking about where their members geographically reside outside, even at a micro level from the town, will be, you know, I think they think, oh, we have a lot in Boston, or oh, we have a lot in Brockton, but they don't go a little narrower into a place-based, like 123 Main Street. I don't, you know, I think housing authorities may or may not be the right folks to be contracting with ACOs. I think it's more about the service coordinator, if there is one, or people at the housing authority, making sure that folks are getting all the benefits they can from an individual basis. And maybe that's a good segue. I know we have. Oh, yeah, go ahead, Joyce.
Hi, Joyce Tavon with the Mass Housing and Shelter Alliance. So as I listen to this, it's so flexible. It seems, I'm trying to understand like the end goal after 2022, because it seems like you could come up with so many interesting projects, so much innovation. So is the intent to test those things that will then get mainstreamed by MassHealth, by the state, and also is in the selection of project, is that going to be a key determinant? You know, is it, oh, this project can serve 50,000 people versus what has the potential to be mainstreamed?
It's a great question. So in the healthcare world, I like to say that we're apparently discovering public health for the first time. So
they named it something bright and shiny.
Yeah,
social determinants of health, like it didn't exist before.
Yeah, so it's
my favorite part.
It's the key phrase, right? I would say from like 2016 onward, now this like, we should think about the social determinants of health. It's now a thing, right? It's just public health. It's the thing you guys do all the time. They sort of discovered you were here. And so, and that's kind of why I said, like, we're all about behavioral health, LTSS, and physical health. And I did behavioral health access work for a long time, and got a really strong place in my heart. But I was also a public health major, so it's funny to me, it all goes together. But so part of that is this, right? Like and if you like are kind of in that field, what you'll know is like the head of CMS said about a few months ago, like, you know, CMS is now considering whether or not housing comes in to, you know, as a service, right? There's about 3 or 4 other states in the country that have received this type of money. It's sort of like the new popular thing to see if you can marry these two things. So I think with that framing, there's that going on, right? So in our world, it's like, does it fit in this model? So the state has moved to this capitated, which means, you know, a lump sum of funding for all your members, and this idea of whole person care. Can we include this, or does it not really work? So that's one question. And I think then there is that level of innovation question, is if I think we knew 100% the right choice of all these services, we could pick it. But I don't think we know that. And to make it more complex, we might know that this program works as it exists in this operational framework today. But can it come into alignment? One of the things I think is an opportunity to see is, and I think, you know, one of our colleagues said this the other day, like, our members, like, they don't exist, your consumers, they don't exist in a bubble. They go from everywhere, right? And they come to us, they come to the world of housing, they go to the world of nutrition, and sometimes we all exist in our silos, and in great opportunities we align. And like, does this alignment work? I think is the broader question, and then how does the alignment work is the more narrow one. Karen.
Hi, Karen McCray from Transit Health. So, I mean, it's sort of a follow-up on Joyce on that. What I'm unclear about is what's the accountability to the SSO in this? Are we looking at, what are we trying to demonstrate, even when you get more granular? So say you're partnering on housing, right, or housing coverage. Are we looking for housing retention? Are we looking for return to homelessness? Who's driving what those measures of accountability will be? Will those be defined at the ACO, SSO level, or at another level?
Great question. All right, so we'll talk a little bit evaluation, and Max will keep me honest because he is moving our evaluation swiftly forward. So because we get a lot of funding from CMS, both at the federal level and the state level, we want to know if things work. So as I said, this whole ACO, I mentioned this community partner thing, so we have this very large evaluation going on of this program from an independent evaluator. At a very high, like, healthcare level, using healthcare always to refer to medical at this point, we will look, and MassHealth will do the work to look at the following. We look at, is there a reduction in utilization? So particularly like your ED usage. Does that go there? Of healthcare utilization. Does your ED
MassHealth.
Yeah, thank you. Tell me, to be honest.
I'm good with the question.
Yep. MassHealth members particularly. We will look if there is what we call ROI, return on investment. So did costs go down? We will look across the spectrum to see if, like, the appropriate utilization, you know, maybe like more people are going to their primary care doctors, but less are going to the emergency room. So to do this, a few things have to happen. One, the ACOs will need to give us data about who's receiving flexible services. And so I'll give you the really quick 101 and see if you can keep me with there. So we talked about these different streams. We have pre-tenancy, and this is in the level of reporting. So there's tenancy sustaining, there's pre-tenancy, there's transitional supports, and there's home modification. And then there's nutrition, because nutrition is less complex in some ways. And so we will be telling the ACOs, the people that receive flexible services on a semi-annual basis, you need to tell us who's getting it in those 5 buckets. And you need to break it down by quarter. So that likely means that if you're working with an SSO, who knows who receives the service? The SSO. And so the SSO will likely need in their contract to have to report back to the ACO who received that. And we're working on standardization of these templates so that if you end up working with more than one ACO, the reporting is standardized. From there, we think that's only half the battle because it doesn't get at the heart of what we're doing, right? And I feel like I always give this impassioned speech about wanting to know about, like, did the member get housed? Did the member get food, right? So what we're doing on that end is a little bit more in open policy development, and I would say we're being very creative about it, and more to come really hopefully soon. But our considerations on that are sort of the level of the amount of burden we can potentially place on people to collect information versus the amount of need to know what's happening. At the ACO level, I think they will also be asked to create their own evaluation of the programs, and we'll be looking at those as well. And those will likely include in your contract, and Emily will say this, I think, like when you're thinking about what a right rate is, you have to think, they're going to want me to collect this data, right? Just like any other grant that you might work with. So that's some things that you're going to have to think about. A lot of information, the really loaded question. The really easy answer is we're trying to cover all of our bases, but yes, there's a lot of work on everybody's end to get those bases covered.
Other questions? Joe?
Yes, and before the question, I do have one basic thing that I have to say. It might be because as I'm aging, my expectations have changed, but I have to say it's probably the fact that I'm sitting in a room where MassHealth is talking about housing and homelessness and chronic homelessness. Really, quite honestly, it's nothing short of miraculous. I'm grateful for that.
I thought you were going to go the other direction.
No, because again, we remember a time when it wasn't quite that wasn't. So I want to say that up front. However, you know, if I was really cynical, again, because of the service-based nature of this particular program, those of us who are very concerned about housing people, oftentimes who haven't been housed in years, it can come off across almost like sounding like another person to be able to approach those people and say, gee, I'm sorry, I wish we had housing for you. And so opportunities like this don't present themselves that often, but we have the HCD in the room. We have the Interagency Council on Housing and Homelessness in the room. We have the, I don't know exactly, but the housing czar from Elder Services in the room.
And we have don't forget MassHealth.
We have MassHealth in the room, of course, always some other notables. But the question really is, how is this now an opportunity, perhaps, to further and advance a plan to meet the housing needs of the medically complex and chronic homeless that exist? And perhaps, you know, are we close to that? How are we moving forward with that as an integrated approach across all of these state agencies to address that very specific problem, to really get to the so-called functional zero in our state?
I think you're right.
I don't know that that was directed at you so much.
You want to talk to like the higher up?
That might be a Lynn question to answer. I think it was more around and you know, broad housing and
close, right? I mean, thanks to the work that you've done, is we're very close to having the data warehouse being set up. I can think of extraordinary ways of working together with MassHealth around identifying specific high utilizers who are experiencing homelessness, but also, you know, one of the things that I was on the advisory group for as ACOs emerged, and it used to just amaze me that DHCD, as best I remember, really wasn't on those groups. You know, how can we use this now and information to reach benchmarks, to set goals and objectives, that through an existing permanent supportive housing agency network that's out there right now of different providers who do this, to be able to solve it once and for all. It's not, as we know, it's not an incredibly large population, but it uses up a tremendous amount of resources as well as taking up tremendous amounts of shelter capacity.
Also, in answer to your question, and so Roger, just so happens that we have a meeting right after this, and we are going over what is our benchmark case.
This is Lynn Tordo talking.
Sorry, this is Lynn Tordo from the ICHH. So a couple of different things. I think one of the things that is important to point out is that there seems to be an alignment, which you pointed out, Joe, which we haven't had before. We've had very strong leadership at the ICHH from Secretary Sutters and Secretary Ash, Undersecretary Cornegay, and now Undersecretary Chan, around this issue of measurable outcomes. If you will notice in both our state plan to end youth homelessness, our Olmstead plan, and the work that we're doing with Roger's committee to the ICHH on supportive housing and production, we are putting out, we're setting ourselves goals, and we're going to try to meet those goals. And we're going to try to figure out just what are the resources that need to come together in order to get accomplished what we need to accomplish. And we're speaking about the chronic homeless, we're speaking about veterans, we're speaking about our families. I think the opportunities to do this in state government occurs when you're doing things like a procurement, because it's really hard when you've already got existing contracts and the ways people do the typical ways that providers are doing business to kind of move that needle. When you have a procurement, when you have measurable goals, when you have plans with measurable goals, and you're held to those goals, that's when you start to see things move. And I have to credit you, Joe, for being a strong advocate for that, not only on the chronic homeless, but also as a member of our Olmstead committee. And we're about to publish our progress to date next month on our Olmstead committee. But I think that has been an important and compelling argument that you've made, and we are taking it to heart. But the good news is that now we have a whole different set of resources we never had before. And now it's not just all on DHCD or all on mass housing or all on, the provider network to try to do more with less. So I really, again, I think you're right. We really need to credit MassHealth, and we really need to take this opportunity and push the envelope. So while the ACOs may find this, difficult and it's going to be a bit of a challenge for them, I think it's going to be incumbent upon us all, both as state agencies as well as providers, to push them and say, if this may be a leap for you, but we're here to lock arms and move ahead, because we can't lose this opportunity. We have to embed this resource in our work going forward. We cannot just always have dedicated state appropriations for every single special population. We have to institutionalize this work and the services that support homeless people, and homeless people have to be at the top of our list. So that's my 2 cents. So thank you. We will stick around for questions. I'm just conscious of time, so I just want to do a little bit of a wrap up. I started off the day talking about you could be in the room for one of two reasons. So the first reason is that you as an agency work on an individual level with people who might benefit from this flexible service resource when it's available. And in that case, you're going to want to know that it's there. However, there are, that's going to play out. It's going to be kind of, a year from now until we really know which ACOs are doing which thing. How do you figure out if your person's an ACO member? So it's a little bit, it's not going to be like, suddenly floodgates are open and there's all this money out there on the streets. I just want to sort of reality check on that. The second reason you would be here is as an agency to think strategically. Do you want to be one of these new SSOs? One of these, partner agencies? Do you want to contract with an accountable care organization? And I think there's some things to think about as they approach you, as you have these conversations, or as you approach them. Can you take on more work? Do you have the staff? Do you have the capacity to take on more work? What would you need? When an ACO says to you, we'd like you to take on more work, what would you need to make that happen? Do you need more staff people? What kind of staff people?
do you have the infrastructure to do reporting? You know, we're not saying at this point that you have to, you know, be, you know, doing billing in the way that you're billing Medicaid, but you're going to have some billing, some reporting, some accountability, some infrastructure issues, data security. You know, if you're not familiar with HIPAA, we're not saying you have to be HIPAA, but you should at least know what HIPAA is, right? If you don't know what HIPAA is, you don't worry, you don't have to, this is all a blur, it's all fine. Move along with the rest of your Friday. You know, it's not really something where you're going to contract with a healthcare organization. I'm not saying that you have to be able to handle HIPAA information, but you have to know how to keep your data secure. You're going to have very sensitive information coming back and forth. We don't know what kind and how much. So, hold on a second, Joe. So just think about these things. Think about your footprint. You know, and when we've heard there's hundreds of thousands of SSOs out there in the state, are you one that serves just your town, or are you more regional? Does it make sense if you're just your little town and it's a very little one like Spencer, I'm just making that up, do you find your friends in the neighborhood and kind of say, we'll do this on a more regional level, because no ACO is going to partner with 351 SSOs in 351 towns, right? We're happy if they're just going to partner with a handful. So the more regional or statewide you can become, I think you also want to think about that there's 17 ACOs. All 17 may be calling you, right, Margot? City of Boston, they're all calling the City of Boston, that's my call. So 17 ACOs out there. Do you have the interest or capacity to work with them separately? Can you work with multiple ones? What if each one wants a different arrangement? Are you going, you know, this is not a, you know, as a houser, I often feel like when healthcare is even in the room, I'm so excited that they're willing to do anything that it's like, okay, I'll take whatever you're going to give me. But in this, I want to make sure that you realize this is a negotiation. So if you have an arrangement that works and you say that I'm working with ACO 1 like this, ACO 2, this is what works for me. You're okay. You can have those negotiations. You're not, this is supposed to be an equal kind of negotiation and dynamic. Think about data. Think about, you know, somebody asked a question of whether or not the ACOs have the addresses of the shelters, which are, the individual ones are online, and we'll make sure they have those. But think about the data that you have. They don't know, there's a lot of questions right now as they're thinking about their flex services as to how do we get access to HMIS? What is HMIS? And how do we get access to homeless management information system? Are there ways that we can figure out where our members are? I even heard, well, can we set up something where it'll ping us if the person shows up in the shelter? I don't know that that's going to happen. I've tried to make it very clear. I've tried to make it very clear that there is homeless management information systems data out there that's maintained by these groups called continuums of care, and that they can be talking to them about them. And there are, you know, as with any other healthcare information, there's rules and regulations and guidelines around what information can be shared. And that but they'll be thinking about how to share information from both a care coordination, but also I think they're not always sure how much of their where everybody is, and you know, maybe the address isn't the shelter in their MassHealth portfolio because it hasn't been updated, but that's where they're staying. For those of you who are like, I have no idea, this was like 2 hours of my life that I'm never going to get back again. Thank you for your patience. But I'd also encourage you to think about just the people you work with. The things that I have seen just living more inside MassHealth than I've ever wanted to be is that people are losing their MassHealth coverage. They are churning through the system. I have been able to do some data sharing with the City of Boston, and I will tell you, of like 800 members, 200 had lost their coverage, right? So, and they've had it the year before. It just means that they're just not filling out paperwork. So I love Housing First. I'm starting to say MassHealth First too. That really you need to not just wait for that emergency to happen, and then say, oh, well, let's make sure your MassHealth coverage. It needs to be on an ongoing basis, or else they're not going to get feedback or flex services or anything else. You also need to make sure it's the most robust coverage. I find that people are on MassHealth, but just because they went to the hospitals or they're on what's called Health Safety Net, or they signed up for something and, there's like 8 different levels, and they just didn't say, oh, I actually do have, maybe they didn't want to, a behavioral health need. We did something again with the city of Boston recently where they invited 50, I think it was, chronically homeless people, and they got housing and stuff like that. And I brought MassHealth, and we upgraded the MassHealth status of 45 of those 50 people to the right kind of MassHealth status. Because you're not eligible for any ACO flex services or a lot of these other managed care fund things unless you are MassHealth standard, common health, or family assistance. And everybody, when I did all this thing, they were all on Care Plus. So, and all they had to do was say, I have a special health care need, and they said, great, let me put you on SID. It's not always that easy. But what I will say is your job, if you've got nothing out of the day, your job is to help people maintain their MassHealth coverage, get the most robust coverage, and think about inviting more people to your group meetings. So continuums of care that meet regularly across the state, invite the ACO. They may be really confused, but they're starting to become players in their community. We actually have one member, a woman, I'm going to call her out, Linda Weinreb, who is on the Fallon ACO. She is on the Central Mass Housing Authority, the Central Mass Housing Alliance Continuum of Care Board. She probably has no idea what they're talking about half the time about the HUD stuff, but she is interested in the topic, and so she partakes and is involved as she can. The last thing I want to say is we have CSH in the room, we have ICHH in the room, and USICH, a lot of CHs in there. You don't have to know all those acronyms, but they are sponsoring events on May 10th from 10 to 2 in Marlborough, and hopefully the registration information will go out soon, which is really meet and greet, a speed dating. So if you walk away from this and you go home and you think about those questions I asked you and you're thinking, yeah, I'm going to take a chance. I think my agency is in a good position to contract with an ACO to deliver some of these services, and I think we could discuss that. Come to that meeting, because that meeting will be really where we bring the ACOs and we bring, and that's sponsored by other agencies, and they're going to just sort of do a speed dating kind of thing. So there are other types of meetings in that respect as well, but only come if you think, yes, this is something I want to do. If you want to know more about the details about eligible services and eligible activities, we're not going to cover that at that. So if I haven't scared everybody, does anybody have any questions or more questions online?
Will you put up with a follow-up question?
Will I what?
Can I give you a follow-up question?
Sure, go ahead, Joyce.
So this opened with discussion of a lot of flexibility and things you can do.
Yes.
But what I heard in what are going to be the evaluation criteria, the number one thing was, is there a reduction in mass healthcare utilization? So that would suggest you really need to be doing some targeting here. Because I'm thinking like, all right, if you gave someone a security deposit, that's not necessarily going to connect to reduction in mass healthcare utilization. So I'm just wondering, am I misinterpreting this, that within that flexibility, you really want to see some thinking about what are the high costs people currently have in mass health and what's going to bring that down?
Yeah, I think you're, so bringing it back to like the 10,000 foot level. So this whole ACO.
Can you repeat the question?
Yeah, so let me see if I can get really high level. So the question was about this, it sounded like it was very flexible, but the evaluation sounds like it's very targeted based on what we call actually like total cost of care of a member. So when we look at it 10,000 feet in the air and remember that this is sort of the MassHealth initiative, what we generally are not trying to do here is recreate what is done at DHCD, what is done with DTA. These are organizations that know their work, that do it well, that we respect. What we are looking at is that whole person, right? And it's how to get high quality care for that person. And that's when I said more to come on how to improve their health outcomes, their what we call it social outcomes, which is like, do they become food secure, that type of thing. And then was there a reduction in cost? And those are the things from like a MassHealth basis that we have to think about our members. And so we are looking to partner to an extent on those levels. So ACOs will be asked strategically, why are you targeting this population? There's a need everywhere. We get that. And I wish we had all the needs we could do, but they're going to probably say, based on our analysis, these are the folks that we're going to focus on because we can move the needle on quality and cost.
So I'm just conscious of time. So we're going to stick around and we will answer questions until we're kicked out of the room. But I put on the slide, this is the list of the ACOs. We've been kind of just talking about them generally. As you can see, their names that just flow off the tongue. But some of them are just a little bit clearer that they are serving, there's Berkshire Fallon Health Collaborative is really in the Berkshires, right? There are some, I'm going to say South Coast, which is kind of on the South Coast of, the Southeast area. But many of them are statewide, and many of them are kind of have pockets where there are ACO members in different areas. So I'm going to just close and thank you for coming, and thank you to all the sponsors. And your name, we will get the question. There's a question about when the recording is being available and where it's going to be. We're going to work on that. And if you have registered and you have your information out there, we will send out future information, including information about the May 10th meeting to that group, to that listserv. So thanks for everybody coming in, and we're going to stick around here. Thanks to everybody on the phone. And thank you, everybody. Have a good Friday.